Bingo, we're live. Hello, everybody. Welcome to our Easter Sunday and Passover Saturday show. And I'm Dr. David Burns.
And
you guys have to introduce yourselves now.
And I am Jill Levitt, Dr. Jill Levitt.
And I'm Mike Christensen. It's good to have you back, David, after you were off last week sick. You sound like you still have a little touch, but you're looking fabulous, I must say.
Thank you. You guys look fabulous, too.
Must be the trick.
So Jill's going to kick us off. We're going to have OCD Part 2 today because we have a lot of really tremendous techniques for fast, drug-free treatment for OCD. The majority of the people I've treated with OCD have gotten better and, I have recovered really pretty completely in a handful of sessions. But we have a whole rich palette of techniques we want to share with you.
Yeah, and if people were with us the last time we broadcast, which was 2 weeks ago, we talked about someone who had written an email to David, and we discussed some strategies for dealing with his OCD. We talked about using a daily mood log to kind of get at the very specific thoughts that were driving his anxiety, and we demonstrated a role-playing method called externalization of voices, which is one of many, many methods that we could use to treat OCD. And we also talked a little bit about how exposure and response prevention has a lot of data to support it in terms of treating OCD, but that everyone who has OCD, just like everyone who has anything, is a unique individual, right? And we need to work as a therapist to really understand kind of the specific thoughts and behaviors that are driving the emotional distress.
That's right. And while everyone has heard about exposure and response prevention, we really use a much more systematic and comprehensive model. And exposure and response prevention always has to be one of the techniques you use in the treatment of OCD. But if that's all you have, your effectiveness with many patients will be limited. And so I use 4 models with every OCD patient, every anxiety patient. So today we'll also not only talk about, exposure and response prevention and how mind-boggling they can be, we'll also talk about therapist fears and patients' fears of using those techniques. We'll also go into this really incredible hidden emotion technique. It's absolutely mind-blowing. Most therapists don't know how to use it. They're not at all familiar with it, and it really adds a lot of power to your arsenal when you're treating any form of anxiety, including OCD. And then we've got the motivational model, looking at outcome resistance and process resistance. We'll talk about that a little bit today too. And then we've got at least 50 cognitive techniques that can be helpful. We won't have time to go through all of those, but there's a whole lot of good stuff now.
It's just incredibly freeing as a patient or a therapist with anxiety to know that we can attack it from a variety of different angles. We're not a one-trick pony.
Yes, and from that point of view, I have really enjoyed getting stuck with patients. It rarely ever happens anymore. Most of the patients I sit down with have a complete blow away of symptoms in about 2 hours, and if that's 1 2-hour session, that's all she wrote for most people. I had another fabulous live session at my workshop in Lancaster, Pennsylvania last week, and the woman had struggled for more than 30 years with progressive multiple sclerosis, and she was just so beautiful and so courageous during the live demonstration. She stole away the hearts of all the people who were there. But when I have a patient who doesn't just recover quickly, that's super exciting because that helps push the boundaries of what we know and helps us develop new treatment techniques and new training techniques. So Jill will kick us off on this great topic.
Well, let's see. So what we have from time to time, people will write David and ask about their own problems or being stuck with cases and things like that. And although obviously we're not doing any kind of, therapy or even any kind of live supervision, we figured we would use an example of someone who had written to David. And so this person shared with us that he has, I think he kind of self-diagnosed himself as saying, I have reading OCD. And I think, if I'm remembering correctly, has struggled with some different kinds of OCD over the years, OCD focusing on different kinds of things. But at the present time is saying that he's really, really struggling to get through books because he is worried that he's not obtaining the information that he needs to obtain, not retaining the information, and therefore reads and rereads and kind of keeps going over the material. And so he can never really kind of get through anything. And this is really frustrating to him.
And he also said in his original note that if it's something trivial, like if he's in a noisy bookstore and he picks up a book and reads something at random, he can read at normal speed.
Yeah.
But if it's something that's important to him, a favorite book, he can't finish it. He just reads sentences over and over and paragraphs over and over, and he worries tremendously that he's going to miss something. And these are the two components of most OCD patients: the obsession, the fear. Oh, it'd be terrible if I don't. Something awful is going to happen if I don't read this properly. And then the compulsion, the habit you get into doing something over and over again to really relieve your anxiety from the feared obsession. And so his obsession is, oh, I won't get it right. I won't understand everything just perfectly. And then the compulsion is this reading things over and over again.
Yeah, and that's a good point you made, even like diagnostically. So the fact that he could read something that feels kind of superficial and unimportant with ease and then struggles when he's reading something important is obviously really helpful. Because of course it's possible if someone tells you they have difficulty with reading that they actually have a reading disorder, a learning disorder, something like that. And this is clearly not the case. He has no problem reading and no problem kind of buzzing through stuff when he doesn't feel pressure to buzz through it. But as soon as he feels that this is important material, then essentially he starts to doubt that he's learned what he should learn, and then starts to read and reread, which takes so much time and is also incredibly frustrating. So he was essentially asking you and us to think about what he could do to help himself, right? Kind of self.
Absolutely. And the fact that in the past he's responded very well to exposure and response prevention means that there's an overwhelming likelihood he will respond to those techniques again. But we have tons of other techniques as well if the exposure and response prevention isn't completely curative. Should we read his daily mood log?
Yeah, I was going to say he shared with us the upsetting sort of, if we do a daily mood log usually to even just gather information about what are the thoughts or the obsessions that this patient is having. And the upsetting event that he described was that I have trouble reading a book easefully, and that he ends up feeling sad, depressed, down, and unhappy about 70%. I noticed, David, he doesn't have a good rating for anxiety here, which seems unlikely.
I got another email from him later, and he added all these other emotions that he had. But I didn't type them in.
We would imagine he would be feeling a really high level of anxiety, since that's kind of what would then drive him to do the compulsion, the rereading, right? And that he also feels and shame. And then he also feels a feeling of hopeless, discouraged, pessimistic at like 80%.
And inadequate because he feels he doesn't read as well as other people, and he doesn't read as many books as other people. So like most individuals, he has, all different kinds of negative emotions, most of them pretty intense.
Yeah. Do you want me to read the thoughts too, or did you want to read those?
You're such a better reader than I am. I might have to read them repeatedly to make sure I get them right.
I was going to say that's because I've been rereading them. No. So the thoughts that this person has is, I will never get back my pleasure in reading a good book, which I could imagine would lead to feelings of hopelessness. I miss out on a lot of great stories by not reading famous authors. I treat those great books unfairly by rereading sentences or paragraphs over and over because it disrupts the flow of events. So I just want to kind of reiterate. So on the one hand, he's telling himself, you're not getting it, so you need to reread it. And then on the other hand, he's also telling himself, you're ruining your reading experience because you're rereading it, and your rereading disrupts the flow of events. So it's kind of damned if you do, damned if you don't, right?
Right.
And lots of pressure and anxiety. Other people who have overcome this type of obsessive reading say they use mostly ERP, but I don't know if I would be successful at applying it.
And ERP, for those of you who don't know, it means exposure and response perfection.
And then he's telling himself that since I'm a perfectionist, I have to comprehend every single sentence rightly. And that would be a very common OCD belief. I must, comprehend every single sentence correctly. In general, I'm not sure if this is a negative thought, but in general, I don't have problems with reading when I pick up an ordinary book and open a page randomly at a bookstore, even in a noisy place. However, I can't even focus on my favorite book, no matter how silent my own room is at night. And you guys see, I'm sure David and Mike, you see it, but this is what we call a hidden should statement, right? Like this young man is actually telling himself, I should be able to focus on my favorite book, and I can't.
Right. It's also kind of a description of the event.
Right.
Supposed to be in a negative thought.
Right. The negative thought that you would glean from that would be, I should be able to focus better than I am, right?
Right.
And I think the next one also is just a description. I feel less stressful when I'm reading a paragraph if I've already read it before.
Yeah, that's more of a description of what he does.
Right.
And then I asked him to do a downward arrow chain. That's where you try to get at the beliefs under the surface. And he did this on his own. He did a really good job on his own, by the way, without any supervision from me or from a therapist. But his when you do a downward arrow chain, you say, if that were true, what would it mean to you? Why would it be upsetting to you to try to get at the deeper beliefs underneath the problem, so to speak? And his first one is, since I'm a perfectionist, I have to understand every single word correctly. And then if I don't, that would mean I'm betraying the book. And then if I betray the book, then I can't bring myself to believe that I have properly read it. And then if I haven't read it properly, I can't proudly and with my mind at ease tell other people that I've read that book. And then I would get the feeling that I've read fewer books than my friends or the other people around me. And then I would compare myself to the people around me and believe that I'm inadequate. And then that would mean that I'm unable to develop myself intellectually and have a lively imagination like other people. And when you do a downward arrow chain like that, I don't have the list of 23 self-defeating beliefs in front of me right now. I generally I could have prepared that for the show today, but this is a list that I've developed that I hand to patients to say, now look at this list, look at your downward arrow chain, and see if you can identify what your self-defeating beliefs might be. And what would you say, Mike and Jill?
There's certainly a perceived perfectionism in there. Unless I do it perfectly, then people, will look down on me. I have to do it just exactly right.
Absolutely. And to build on that slightly, he seems to have the idea that he has to impress people to be loved and admired and to be accepted. He doesn't have the idea that it's okay to be a vulnerable and real human being. And I got some tremendous additional emails about the live therapy session with Marilyn, who that's on my podcast, my Feeling Good podcast, and she had a diagnosis of stage 4 lung cancer, and then began to beat up on herself because she had lost her religious faith, and she was angry at God and ashamed of being angry at God. The same kind of perfectionism, and it was just so interesting, the outpouring of love that she's received from people. And that's one of the big surprises, I think, of good therapy, that you discover that what you thought was your worst flaw, your greatest failure, is actually your greatest triumph. And that's, I don't like to take a religious bent, but that's also kind of a religious message in Christianity, and I think in virtually every message, that when your ego dies, then there's a resurrection. You get new life, and I think the Christians put it in their terminology and their symbolism. The Buddhists put it in their own symbolism. I don't know if it's a component of Jewish theology. I would assume it probably is at some level, probably woven into every religion. But this poor fellow, because of what you said, Mike, here, his perceived perfectionism, he doesn't have that idea that it's okay just to be a guy, okay just to be human. And the same with the one from 2 weeks ago. He's thinking he has to be sexually perfect, and
Exactly.
and if he's not like the greatest lover in the world, then he's a loser, and his wife will leave him. And there's a tremendous loneliness associated with this. What other beliefs do you see here, Jill or Mike?
Let's see.
One of the other ones I was thinking was the Superman, kind of Superwoman, where I always have to kind of be, in control.
Oh, yeah, right.
And in top of things.
Maybe even what we call the spotlight fallacy, right? Which again goes with this idea of just that I need to be impressive to other people, right?
Yeah, and also the brush fire fallacy is another self-defeating belief. If one person disapproves of me because they don't read much, then they'll tell others, and they'll tell others, and the word will spread, and I'll be hated by thousands or millions eventually because of my slow reading. By the way, it's just kind of coincidental, but I think I have personally only read about 2 books in my whole life, to be honestly. I'm a real slow reader, but I just never saw it as a problem.
Right.
I also read. I don't read much because I am so slow. Even on TV, when they flash those things.
I'm so smart.
What?
I thought you were saying because I'm so smart, I don't need to read.
Yeah. Well, to tell you the truth, I think I learn more from teaching and from my patients and from my cats and from you guys. That's the kind of learning that I love.
I want to say one quick thing, which is just to get people to see, we're using one specific example of a person with OCD around reading, but this idea of perfectionism and then perceived perfectionism, which is a little different. It's not just that I need to be perfect. It's that I believe that other people, would look down on me if they didn't perceive me as perfect. What I was going to say is that this idea, it drives a lot of anxiety for a lot of people. And whether you're a therapist trying to look for strategies to help your patients or just a person trying to help yourself, I think we can all ask ourselves, are there moments in time where we define ourselves by like, if I'm not this, or if I don't do this just right, then I'm bad or I'm worthless. I think that's such a common struggle for people.
Well, and if you guys want, we can have a future show on that very issue. I've been writing about it for my new book, and there's 2 issues. Can the self be judged? Do we have a self that can be judged by others? Like, we can judge the show today. You could rate it on a 0 to 100 and give it a rating of 80 or 90 or 60. You can judge how we do on this show in any of a number of dimensions.
Right.
But you can't judge ourselves. That's the first thing, is to discover that the self can't be judged. And then the second thing, once you've discovered that, is the discovery, if you are willing to make the discovery, that we don't even have or need a self. And that's what the Buddhists call the Great Death. And in my new book, I'm talking about 4 great deaths. There's a great death that corresponds to recovery from depression, one for anxiety, recovery from anxiety, a third great death in relationship problems, if you want to get close to someone you're ticked off at, and a 4th great death in recovery from habits and addictions. And that might make for a fun practical and philosophical show in the future. But this fellow, he feels that somehow his self is measured by this flaw that he has. And that's where his pain comes from, because he thinks he's not lovable if he has this flaw. How are we going to treat him, Jill and Mike?
Well, initially, we're going to do some empathy with him and make sure we're connecting. And then the next part would be our agenda setting. We need to find out if he actually wants help with this. Maybe this OCD is serving him well, and it would be a disservice to him if we turn that around.
Absolutely. So we could do positive reframing like we did 2 weeks ago. What would be the outcome and process resistance for this problem, Jill?
So and just to explain to our listeners, when we talk about outcome resistance, we're kind of asking ourselves as a therapist, and you can ask yourself as a person, like, what are good reasons not to change? You know, why is this person, even though he's coming and saying, please help me, I want to be able to not be so anxious about my reading and to be able to read without rereading. What are good reasons for him not to change? And we can say that, you know, his reading and rereading and kind of obsessiveness speaks to his high standards, right? That he, you know, he may not want to give up his high standards, his knowing everything, right?
Yeah, and that's kind of like the death of the ego, right there.
Right.
You know, he wants to keep this concept of himself as this, as you said, Mike, as this Superman. And I did that for years myself when I was starting out my clinical practice. I was kind of perfectionistic and thinking I was going to cure every patient, and it was a big deal if I was stuck with somebody. I couldn't take it, and I had to prove to the patient that I could cure them. And then I got into power struggles with patients, but I was addicted to this idea that I was going to become this fantastic therapist, and that I wasn't going to be average. You see, right. And then at a certain point, you know, a patient said, "Dr. Burns, you're not helping me," and I said, "You know, you're absolutely right, and I feel terrible about it. I haven't been connecting with you, and you have every right to be angry and disappointed. Let's talk about it. I want to hear how you've been feeling, what's been going on." And then suddenly the heavens opened up. And once I accepted that I didn't have to be special, then I became far more effective as a therapist because I could relate to people so much more deeply. It was a
right.
paradox. But you see that here, and with all you know, OCD patients and a whole lot of anxious patients and depressed patients that you get in love, addicted to this view of yourself as being, you know, fantastic in some way, and that's the price. One of the prices of recovery, that part of you has to die, you know, if you're willing to let that part of yourself die.
And that might be confusing for people because this fellow is not a perfect reader, but what he is he's holding on to the standard that he should be a perfect reader. So it can be a little confusing, but basically what we're saying is you'd have to lower your standards. You'd have to be willing to accept yourself as someone who can read a book and not retain everything, and not know everything about the material. David just disappeared on my screen. Is he gone?
I just came back. I disappeared.
Oh, see, you died and you were reborn.
I just had death and resurrection.
Perfect.
It is Easter Sunday, so well done.
Days.
Right.
It took 3 days. It was like just 5 seconds.
Oh, we're bad.
Yeah, we're bad. Now, how about outcome resistance, Jill?
Yeah, I'm just saying that for people might feel a little bit confused by that. What we're saying is he'd have to lower his standards. He'd have to be willing to say, it's okay. I'm even kind of proud of the fact that I'm a mediocre reader, right? I don't know everything. I don't remember everything. Kind of hallelujah, rather than holding on to this, I must be this excellent thing in order to be happy with myself or in order for people to like me.
Right. And he'd also have to be willing to face his fear on multiple levels. One, you see, he makes, by reading slowly, he's avoiding this fear of not understanding everything.
Right.
And so he'd have to be willing to give up that safety.
Right.
And he might not want to do that. He might want to continue with this slow reading. And then I would say, you know, God bless you. Go for it. You know, you probably read that sentence better than anyone else in the world, and you know, you've really got what that sentence means. But then what would process resistance be? If he said he really does want to recover, what's he going to have to do in every anxious patient and every OCD patient that he is not going to want to do at all?
I'll let Mike answer.
Sure. Yeah, he's going to have to face the fears head on. do some exposure, in addition to some of the homework, some of the cognitive work.
Sure.
But he's going to have to face that fear head on. He's going to have to read without kind of rereading and potentially face other people that might ask him questions about the book and not know what the answers are.
Yeah, and you might have to take a speed reading course where they actually force you to read really quickly, and that would make him really anxious at first. And he would also have to do response prevention. How would that work, Jill?
Sorry, I was just reading some questions, but
we're getting
I was reading some of the live comments while Mike was answering. But response prevention, well, I think in the same thing, he would have to not reread. He would have to commit to not rereading, right? So he would have to be willing to. He would have the obsession, like I should reread. I don't know enough, and not engage in the compulsion, which is the rereading. Yeah. And even if he were doing mental review in his mind, he'd have to stop doing that. So he'd have to tolerate the discomfort associated with being, just knowing a bit.
Yeah, absolutely.
I was noticing that one of the questions Eric asked was, he said, do the reasons for not wanting to change, the outcome resistance, have to hold true for him? Or is it just a general list that you come up with as a therapist? And I thought that is a great question, because it absolutely has to hold true for him. It's right. This is a good question for someone to ask. We don't just come up with some generic list and think, here's why all patients resist. In fact, it's much more, specific to the patient, and much more collaborative with the patient. The patient says, no, that's not true. Then we think, well, what is true for you, right?
Yeah, absolutely. And Eric, by the way, has been blazing lately. He writes to me frequently, has been developing tremendous insights about OCD and other things, and I've really been enjoying your correspondence, Eric. Phil asked a great question. This can bring us to a second dimension. Any hidden emotions operating here? He's focusing on one thing, reading, but is there anything else going on? Well, I think that's tremendously insightful, and we can't figure that out without talking to him. And that would take, a little while during the therapy session, or maybe it might take a few therapy sessions to figure that out. But I can give you a brief clinical example of that, and then maybe we can give some examples of exposure too. I know you were mentioning a cool case, Jill, but I was asked to treat a medical student years ago. He had a good 20 years of failed therapy for severe OCD, and a faculty person referred him to me, and he gave me permission to kind of use the details of his treatment in a general way. But his thing was, he kept developing the obsessive fear that he had AIDS. That was his obsession, and it was totally irrational, because he was engaged, he was faithful to his girlfriend, and she was faithful to him. There was no reason for him to think that he had HIV or AIDS, but he would have the typical OCD thought, well, what if I pricked myself with a needle when I drew blood from a patient with AIDS, and then forgot that I pricked myself with the needle? And then, so it's theoretically possible that I do have AIDS. And then he would obsess about it. He'd eventually go and get a blood test for AIDS, which of course they always came out negative. He'd go to the medical library, and read for hours about AIDS to see if he had any of the symptoms. And it was massively consuming his life. And this was a fellow for whom exposure and response prevention had zero helpfulness. Traditional psychotherapy had not helped either. And so I was using the cognitive model and the exposure and response prevention model with very little improvement at all. And then he called me on a Saturday morning in a panic at home. He go to the emergency line. He said, "Oh, Dr. Burns, I believe I'm dying of AIDS, and I have this incredible compulsion to go to the emergency room and get a blood test and be checked out. What should I do?" And I asked him a couple of questions, and then I suddenly saw the hidden emotion. And I'll let you figure it out, Mike, although you two may know the answer already, which will make it too easy. I know I told you, Jill, the other day, but Mike, you might have heard it heard it. But what happened was that I said, well, tell me what's going on right now. And he said, well, my girlfriend just 15 minutes ago, she left for New England for her high school reunion. And I stayed here in town because I have to study for finals that start on Monday. And so it was perfectly logical for her to go to her high school reunion, for me to stay here and study all weekend. And he was, by the way, I think, number one in his class. Often the people with OCD are incredibly gifted and intelligent individuals. I don't know if that's an actual finding, but it's certainly something I've observed. And he was like that. And I said, well, how did you feel after she left? And he said, oh, I felt fine. I just suddenly developed this belief that I was dying of AIDS. Now, what the hidden emotion model is, just those of you who don't know it, some people with anxiety, in fact, 80% of people with anxiety are exceptionally nice. And what that means is that, and I'm one of them, I can be pretty grouchy, but I have that same niceness problem. And so when they get an emotion when you get an emotion that you think you're not supposed to have, you sweep it under the rug. You're not aware that you feel that way, and it comes out as any form of anxiety. It could be a panic attack, it can be a phobia, it can be generalized anxiety. In his case, and in many people's, I'd say 80% of OCD patients, this is going on. It comes out as OCD, and then he gets all worrying, I'm dying of AIDS, and it distracts him from the feeling that he has, this forbidden feeling. So what do you folks think the hidden feeling is? I know you know, Jill. So Mike, you probably know also.
I have heard this story before, but I don't remember. So I'll do my best guessing, which is really how we do the hidden emotion.
Yeah.
There's some dynamic going on with him and his fiance or his girlfriend that he's concerned about, and he's not expressing, not talking to her about. Something in that realm is my guess.
So how might he feel when his girlfriend leaves him for the weekend?
He might
goes off to her high school reunion, leaves him alone.
He might be concerned or worried, depending on
the worried is never the hidden emotion. The worried is the anti-hidden emotion. That's the felt emotion. But
he's frustrated and disappointed and lonely and angry that she's gone.
Yeah, that's what most mental health professionals think. Oh, he's angry, and he's not supposed to be angry. That's the most common hidden emotion. But you did hit it. It wasn't anger. It was loneliness. And then I talked to him about that, and he said, well, a man isn't supposed to feel emotions like that. That I'm afraid you think I was kind of a wimp or something like that. And a man is supposed to be strong. And just at that moment, I suddenly saw what had been going on. And I had seen him about eight sessions with no improvement up to this point. And he said, I think I need an emergency session. I said, listen, come in on Monday. I've got an opening first thing Monday morning. Bring your girlfriend with you, your fiance, and we're going to have couples therapy 101. And they came in together, and I just did some simple communication stuff. You talk, and then you listen and paraphrase. Now you talk and you listen and paraphrase. Just simple stuff to get them talking. And I got him to express this emotion that he thought it was logical for her to go to her reunion, and he loved her, but that when she left, he felt really lonely and missed her, and was kind of beating up on himself, thinking that he shouldn't feel that way. And when he told her that, she began to cry, and she hugged him, and she said, I've been waiting so long for you to open up and show me your feelings and your vulnerability. And he said in that flash, he was cured of OCD, and he'd had failed therapy, and he's at the end of the session, he said, I'm 200% cured of this. And then when I say the good news is now that you are permanently and irreversibly cured of OCD. The even better news is that your OCD will come back over and over for the rest of your life. And why is that the even better news?
Well, that OCD is going to act as a fantastic kind of reminder indicators so that when he starts to feel it, he just goes back and uses that same tool of expressing with his fiance, girlfriend, probably wife at that time, what's going on in his life.
That's exactly it, because he may never get there in real time where he can really know his feelings. But when he is doing this, sweeping them under the rug, and then his body, he'll start thinking he's dying of AIDS or HIV or whatever, and that will be his body's way of telling him that this is going on. Well, that happened probably 40 years ago when I had that session with him. And I got a follow-up about maybe 2 or 3 years ago. And he called and he said, "Do you remember me?" I said, "Do I remember you?" It was like, I feel like our last session was 2 weeks ago. I can remember every exchange we had in every session. How are you doing? And he said, "Oh, I'm doing great. I'm he was the chairman of a major medical school division at one of the world's top medical schools. He was the top guy, the chairman of, one of the departments." And I said, "Well, that's great. What are you calling about?" He says, "Well, I was wondering if I could use your anxiety test because I want to do some research on anxiety and its impact on cardiac functioning and stuff like this." I said, "Yeah, that's great. I'd love to have you use it in your research. I'm flattered. But tell me, how have you been doing? I haven't heard from you since our last session, the one after when you met with your girlfriend, and then the next one was our last. I never heard from you again." He said, "Well, it was just like you said it was going to be. 99.9% of the time, I'm totally cured of OCD. But maybe once every year, once every 2 years, I'll start thinking I'm dying of AIDS. And then I remember what you said to do. I go through my appointment book and figure out who I'm upset with. And then I talk it over with that person and it disappears again." And so that's the hidden emotion model. And it's not intended to replace exposure and response prevention. Those tools are still incredibly important, but it's a whole other dimension that can have powerful and mind-boggling, really fast healing effects. But it's tough to figure out what the hidden emotion is because patients are so good at fooling you and fooling themselves. Now, Jill, you were telling about a really neat case to bring exposure to life, and then we could talk about how patients hypnotize therapists into being afraid to use exposure.
Sure, right. So then just to kind of recap, we did talk about the motivational model, because David in the beginning said we have at least, let's say, 4 models for treating anxiety. We have kind of the motivational model, which is when we're talking about resistance, right? And why a patient might not want to get better, why they might not want to, as we said in this case, like sort of lower your standards or accept yourself.
As well as the fact that you think your anxiety is going to protect you from some awful thing.
Absolutely, right, which is so commonly the case, and actually so commonly the case with OCD, right? We believe, if we wash our hands this many times, I won't get this illness, or I'll protect my children from an illness, or if I try not to think of this, then I won't actually be this awful person. So there's sort of the motivational model, and then David has just shared with us the hidden emotion model. And there's the cognitive model, which we talked about last time, 2 weeks ago, and we could always cover more cognitive methods too. But, the one I can talk about a little bit is what we call the exposure model. And so one way of doing exposure with OCD is what we've talked about a little bit before, this idea of exposure and response prevention, right? Where we encourage our patients to actually have the obsession without engaging in the compulsion, right? That's the response prevention. But another form of exposure that's really helpful for many patients with OCD is called cognitive exposure, or flooding. And this is the idea that many times what a patient is worried about is not something that we can actually just confront. So for example, your case, David, this patient who's worried that he has HIV, it's not like we can just then sort of, I don't know, can have him do a lot of exposure to confront his worst consequence, right? And sort of have him tolerate it or habituate to it. And there is some exposure. He probably could handle needles and do a variety of things like that. But cognitive exposures where we actually have the patient bring it to their mind. Usually we have them do it verbally and record it, but we'll talk about kind of the worst thing you can imagine happening, the kind of catastrophic consequence. And so in this case, it might be getting HIV and then dying of AIDS and losing his fiance. He would have to imagine what this worst consequence is. The case I was telling David about was a woman I was working with. And again, I'll, basically have this disguised and not give any great details, but this is a very common one. A woman I was working with who had OCD, who's then worried that she would never overcome her OCD. And when I asked her, really through a downward arrow, what would be most upsetting to you? Why is this so upsetting to you? She was worried that she would become so mentally ill, become institutionalized, and then her children would grow up without a mother. And they would, ultimately end up killing themselves. Now, this also goes to the point of individualizing treatment, right? You would never know this unless you ask the patient, what are you so upset about, right? But essentially what we did, we tried a lot of other methods. We did a lot of cognitive strategies, which are far less aggressive, and they weren't actually useful. So then I said, you know what? I think we have to face this awful fear of yours, and you're going to tell me the story. You're going to imagine and say it out loud, and we're going to record it on your phone. This horrible consequence. And we went through lots of vivid detail of her OCD getting worse and worse, and her not being able to take care of herself, becoming institutionalized. Her children aren't even able to visit her. And the whole thing went, so badly that ultimately the worst thing happens where her children become horribly depressed and end up killing themselves. And obviously this is like a horrible thing. You're a therapist and you're thinking like, how can I make my patient do this? But I knew that there's data behind this strategy. This is what we do. And we did it. And she sobbed the whole time. And she recorded it. And I said, great, you did an amazing job. Now you need to go home and listen to this for 30 minutes a day, every day. And come back and see me, in a week. And by
the way, the instruction would be to make yourself as anxious as possible.
Totally.
Not to try to reduce or control your anxiety.
Absolutely.
When listening.
Right. When she was telling the story, I'm prompting her to tell me even more vivid detail and make it even worse. And how is that the worst it could be? We have picturing this poor young mom, picturing her little children, growing up without a mom and then ultimately killing themselves and listening to this and
have to visualize that.
Right. Totally. Where are they and what's happening and where are you and in vivid detail and making this recording and, but she was very motivated and we had really good rapport and she trusted me and knew that this was, a useful treatment. And so she went home and did it. And yes, she came back, I would say she came back a week later and was like kind of 50% there. Like, yep, I can totally tell this is working. I feel much less upset about it, but it's still hard for me to listen to. I said, great, let's do it again in session and let's have you do it again for homework. And, 2 weeks later, she came back and was like, this does not bother me anymore. Like, I'm bored of this.
Yeah, that's the way it works. I want to comment on reverse hypnosis, but we have fabulous comments, just a couple quickies. Dominic A. Rolla wants us to note, please don't take offense. I find humor is a great medicine. He also tells us, but Dr. Burns, you don't understand. I am a perfect Superman with a smiley face. And I love these comments. And then Phil McCormick, who's always raising really good question, says, don't labels have a negative impact on how people feel, like OCD? And if I'm OCD, I should feel like this. And if I have a major depressive disorder, I'm like this. And if I have generalized anxiety disorder, blah, blah, blah. And so I become and believe in my diagnosis. I'm totally with you on that, Phil, and we could do that on a future broadcast, but I think the whole thing of DSM is pretty screwed up, and while it's useful to have a dictionary to know how we're going to think about clustering symptoms together, calling them disorders, transforming worrying into a brain disorder called generalized anxiety disorder, I think it does a disservice, and it's kind of statistical and conceptually nonsensical as well. We all worry. Most of us are shy, but there's no such thing as social anxiety disorder or generalized anxiety disorder. Those are just made up terms, that there's no biological basis to these things that's been determined. And while there's value in knowing what your symptoms are and measuring then how severe they are so we can show you how fabulous it is when they go to zero and disappear, thinking about these things as brain disorders, I think is controversial and a suspect. But let me go back to this.
Can I say one quick thing about that? The only thing I would say about that, in the same way, David, that we talk sometimes about like what we call the recovery circle, and we say kind of, you know, the good news is we've got all these methods that could help you. I do think it depends on how you describe diagnosis to your patients. I mean, I don't say you have a brain disorder that's called generalized anxiety disorder. I kind of say you have this cluster of symptoms, and you might say the bad news is, you know, we call this generalized anxiety disorder, but as far as I'm concerned, the good news is this is totally treatable. I have a ton of different things that I can show you that we can do together that'll actually help you. So, I mean, I think all of these things also are in the way that you describe it and the way that you communicate it to your patients. I find diagnoses can be useful because they oftentimes, in my mind, can tip me off to categories of methods that might be useful. And then, of course, I have to individualize treatment for the patient.
Communication and language, along with compassion, are tremendously important. And one thing I admire about you, Jill, is your way of communicating. When you teach today, when you're doing therapy, it's just fantastic. It's inspiring to me every time you speak, really. Because of what you just said, the way that you express things is always gentle and lucid, and it's comes with kindness and compassion is so crucial. The reverse hypnosis you have to watch out for as a therapist. And reverse hypnosis is when the patient hypnotizes you into buying into their own distorted beliefs, and patients with OCD will try to trick you or persuade you not to use exposure because they're so terrified. The patient who's washing her hands or his hands 50 or 100 times a day to prevent contamination and thinking they'll get cancer if they don't wash their hands, they are terrified to use exposure and response prevention and will push very hard. Then the therapist has to be very firm with the patient. We call it the gentle ultimatum. If you want me to treat your OCD, you're going to have to use exposure and response prevention, and it's not negotiable. And if you don't like the proposal that I'm suggesting to you, I'd hate to lose you as a patient, but if you just want to go and talk to someone every week, I'm not your guy, because I've never once seen anyone be cured as a result of, or recover as a result of that type of thing. I never once saw any anxiety disorder recover from just general talk. And to give you an example of how persuasive the patients can be and pushing you not to use exposure, a young man, I'll call him Pedro, emailed me that he was from somewhere in South America, and he said when he was a kid growing up, he had severe OCD and depression, and somebody when he was 13 gave him a copy of my book Feeling Good, and he started reading it, and he said within two days he was completely symptom free. He said it was like a miracle, and so he was determined that after college, he was going to get a doctoral degree in education and train all of the people in his country in cognitive therapy, which was what my book Feeling Good was about, and all the good that could do. And then he wrote me when he was about 20 an email that he was in a PhD program in education, and he had been reading a book by Albert Ellis. And Albert Ellis, as you know, is a very anti-religious person. And this fellow Pedro was a good young Catholic lad. And the book by Albert Ellis had a sentence like, who the F, I won't say it, but who the F is Jesus Christ anyway? The implication was that Jesus Christ is just a con man like all the other Buddhas and spiritual figures of history, that they're just kind of frauds and don't have any secret knowledge of any kind. And this was incredibly upsetting to Pedro. And he said in a flash, his OCD and severe depression returned. And he wanted he was emailing me to find out what he should do about it. And his OCD, he started, and this is probably not a good one for Easter Sunday, but he started having obsessions, picturing Jesus having sex with the Virgin Mary in all of the positions of the Kama Sutra. And this horrified him. He found it sexually exciting and equally, terrifying. And he was convinced he was going to burn in hell because of these vulgar, repulsive sexual obsessions that he couldn't get out of his mind. And of course, the harder he fought against them, the more intense they became. Now, what are two techniques we've discussed on today's program that might be helpful to poor Pedro?
Well, one would be the hidden emotion technique, and then the other one is the exposure, the cognitive exposure that Jill was talking about.
Yeah, and that's a great call. And the hidden emotion, he's probably ticked off at Albert Ellis.
Yeah,
who was a fabulous guy, but he loved to insult people, and he was very controversial. But he's so nice. He instead of saying, "Hey, Ellis, screw you" or whatever, he's thinking, "Oh, well, Burns likes Ellis. Ellis must be great. I'm not allowed to be angry with Ellis." So that's the whole hidden emotion thing. And then the cognitive piece is he's going to have to intentionally fantasize Jesus having sex with the Virgin Mary, and he's going to have to do it over and over again until it loses its interest.
Right.
Now, he said he didn't want to do that because then he'd burn in hell. You see, he says, this is not religious. I cannot do that. That's wrong for me to do that. Mm-hmm. And that's what you see with almost every anxious patient. They put up intense, highly individualized resistance. It's different for each person. Mm-hmm. Why I should not have to do or cannot do exposure. And
David, it's very common actually in OCD that people will have intrusive thoughts about things that are actually really morally upsetting to them, right? So someone who's quite religious would have intrusive thoughts that go against their religion, or someone who's a lovely father will have intrusive thoughts of naked boys or something. It has nothing to do with their sexual interest or preference. It's almost like because they're trying so hard to be good, they have intrusive thoughts that are bad. And because of the value that they place on those thoughts as being important, they keep maintaining themselves, right?
Yes. And so, and 75% of therapists buy into that. They will give in and not push the person to do exposure. So,
right.
And then the therapy's, to my way of thinking, doomed.
Because then the therapist thinks, oh my gosh, I don't want to harm my patient or push them to have more of these thoughts, or like a therapist who doesn't know about this and
and then they try to help the patient control the thoughts, and that makes everything worse. Well, to make a long story short, there's someone who's been a podcast broadcast listener on these Sunday shows. I don't think he's with us today, but he was studying to be a Catholic monk at the time. And so I told Pedro, I said, hey, I'll email this colleague who knows a lot more about the Catholic Church. I was raised as a Lutheran, but I'll ask him and see what he thinks if what you're saying is right, if it's immoral or unreligious for you to do the treatment. And so I wrote to this fellow, and he said he didn't know either, but he called a conference of several of the top Catholic theologians in the city where he lived, and they had about a half-a-day debate on it. And then it was very kind of him to do this for me and for Pedro. And then he contacted me immediately within minutes at the end of their 3-hour conference, and he said they had decided that it's permissible for a good Catholic lad, it's okay to fantasize Jesus having sex with the Virgin Mary in every position of the Kama Sutra, as long as the goal is healing rather than entertainment. And so then I went back to Pedro. Of course, he was just an email exchange. I wasn't a therapist, but I said, if you're my therapist, armed with that information, I would have to say, you must do this if you want me to treat you. And if you want treatment without this, then you have to find a different therapist. And that's called the gentle ultimatum.
But you really did quite a survey for him, it sounds like, to, really to allow him to do exposure therapy and to feel like it was legitimate to do so within his religion.
Yeah, but he still has to make a decision if he's willing to do that.
Absolutely.
Check with his own theological consultants where he lives there in South America.
Right.
But that's the art of
Right.
exposure. Exposure, you can learn how to do exposure in 60 seconds. You don't need a PhD in clinical psychology. You just have the patient confront their fear, and if you can make it worse, that's called response prevention. Confront your worst fear, and then you're not allowed to do
No
your ritual.
avoidance, no escape, no distraction, right?
Exactly. But the art of it is in how you implement these things with trust, with warmth, and with firmness.
Right.
So I think we're up for grabs now. We have only a minute or two left. Six minutes left. 5 minutes. We've got Lisa Kelly.
We get to cover the motivational model and the exposure model and the hidden emotion model, right?
Yeah, we did cover them, right?
Yeah.
We covered the motivational, right?
Yep.
The outcome resistance and the process resistance, the exposure model, the hidden emotion model. And we haven't done a whole lot today with the cognitive model, but we probably don't need to do, build Rome in one day.
Are there any more questions from any live comments that we should address?
I'm trying to check it out. I was just saying we've got
any.
Lisa here. Thank you, Lisa, and Phil McCormick and Eric Tramontana. And we've got Susan Cahill. I don't click on like anymore because there is no like when we do this, the Be Live. It says I can click on something to the right called show, but I don't know what that will do to the rights of people's names. We've got Dwight Swaback. Hi, Dwight. Good to see you. Dante Murta says hello. Bernie Balecki, I've been getting emails from Bernie. He attended the summer intensive. I gave him some homework having to do with flirting and other things. And he said that he had a problem with procrastination and then kind of procrastinated. And then emailed me that he's been doing his homework and getting great results. Bernie turned out to be a very good flirter, and it's a skill that some people have. And if you're single, it's a good skill to implement there. But anyway, Bernie is a good guy. He's been to a lot of workshops. I really like Bernie. Sylvia Stewart says, hi, everyone. Happy Easter. We have a public holiday here today, being Monday already, so she must be abroad.
Yep.
I'll just say one thing maybe for the general good. Our Feeling Good podcast this month hit a new high thanks to the live work with Daisy. We've had over 47,000 downloads this month.
That's amazing.
And what we're doing here, we're still at the 1,500 to 2,000 per Sunday episode. And I'm trying to figure out how to improve marketing. Maybe some of our viewers can help us out, because I was humbled. Someone asked me to be on their podcast a day or so ago. I've been fortunate to get a number of invitations. And so I said, well, how big is your audience? Because I'm trying to pick and choose a little bit. And then they wrote back and said they typically get 50,000 downloads per episode. Sometimes up to 80,000. Now that's per episode. My 47,000 is per month. Now it's grown from just 1,000 or so up to 47,000. But I was humbled by this other podcast I'm going to be on with a much bigger. So I'm going to ask them if they can give me any tips on how to increase your marketing and exposure. And if anyone watching, can recommend to your friends or knows any good tricks or tips we can do to get the word out. I'm just so honored to be working with both of you. And I think it's a unique opportunity. Jill, you might be interested that for years at Stanford, I used to have the thought, gee, if Jill and I, and Mike, of course, you weren't in the Stanford group, but could just teach like we do in the Stanford group, we could broadcast all over the place and make this available to thousands and thousands of people. So now we're doing it, and we can improve on it and do a lot of cool things. But it'd be nice to know how people spread this social media and stuff like that.
Right. And we can let people know, I guess, I mean, we don't want to spend too much time promoting things, but we have 1 minute left. And so that your website, David, is a great resource to therapists and patients too, which is feelinggood.com, right? And I actually am teaching an upcoming online course on CBT methods for 6 weeks that covers some of the methods that we talked about. I teach cognitive exposure and other kinds of cognitive strategies too, which is on our feelinggoodinstitute.com website.
Well, and let me give you guys a plug that Mike too has online introductory classes, and you two are two of the neatest people I know and the best teachers I know. And so if any of you would like to really get certified in team therapy or get some of this really good teaching, go to the www.feelinggoodinstitute.com.
Right.
And you can see a variety.
Mike has a course that's coming. I have a course that's coming up on April 16th that starts, and Mike's course starts on April 30th. So both listed in the same place.
Oh, okay, great.
Yeah.
And then on May 20th, Jill and I are going to do a full day workshop. It's limited. Those who can come in person, I think it's limited to maybe 40 in person or something
in person,
like that.
But we can accommodate as many as would like to join us live online. So live streamed that day, May 20th online.
And you can also find links to that on my workshop tab on feelinggood.com, or you can find it on the feelinggoodinstitute.com website and sign up for that. That's going to be a really good one-day David and Jill show with a lot of practice, and we're going to teach you methods and have you practice them as
and
well.
Mike actually will be facilitating the online part of it. So it'll basically be the three of us again.
Oh, for a whole day. Oh,
yeah.
Yeah, that's right. Thank you, Mike.
One more.
So Mike will be there to help those of you who are
join online.
Breakout rooms, so you can actually do live practicing.
Yeah.
One more shameless plug is for your intensives that are coming up in the spring here, David. I know you're coming to Canada, and I'm excited about that in Calgary and Winnipeg in June, and then in Whistler in July. And you can get the details on David's website there, and love to see you kind of live in person if you're coming to Canada. The dollar's real weak up here, so for those in the States, come for a cheap holiday and get some live training from David. We'd love to have you.
Well, I'm going to end it on time. I just want to give a big thank you to both of you. I just love you both, and I also admire you both because you're just so awesome. So everybody have a great
Right back at you.
Yeah, absolute pleasure, David, as always.
Great holiday. And then next week, we're going to have Stephen Fleiter is going to be my guest, and we're going to be talking about all manner of addictions. And then at some point, I'm probably going to have Vandana Aspen, a clinical psychologist who will talk about eating disorders using team therapy for eating disorders. So a lot of good stuff is coming up. Oh, and at the summer intensive, Sunny Choi will be speaking at one of our luncheons on how he works in the community using team therapy in just 35-minute sessions with people, many of whom can't even speak English. They're immigrant population, and he's still seeing most of his patients recover in 3, 4, 5 sessions. So I think that will be very inspiring to people. Okay, so have a good one, everyone, and bye-bye.
Bye-bye. Thanks.
Bye.